Good morning, everybody. Hope you're all doing well. I am pleased to get to spend this time with you. Can everyone hear me okay?
Mm-hmm.
Yeah, so, okay,
Yep.
great. Perfect. Thank you for the thumbs up for those that so my name is Amol Verma. I'm an internist, and I guess I'll tell you a little bit more about myself during the presentation. I was an AMS fellow 2020 to 2021, I think. Those years, I think I have the right years.
Yeah.
And and so I was invited to just come share a little bit with you about my experience as you prepare your applications. And so I'll chat with you a little bit about kind of my experience in the fellowship and the work that I was able to do during that time, and also maybe just some tips around the application. I'm I would love for this to be quite informal. I have slides obviously to go through, but please feel free to jump in and ask questions or interrupt or share comments, or if someone disagrees with something I've said and has a different opinion and wants other people to know about it, like that's fantastic too. I really think I certainly don't come here with all the answers, and so um, let's make this kind of an informal, 45 minutes or an hour, and hopefully that just so you can get the most out of it too. I think the goal should be that you get something out of it. So I'm just going to try sharing my screen here. So hopefully you can all see my slides. Um, okay. So um, uh, my AMS fellowship was titled, "Can an Artificial Intelligence Prediction Tool Improve Compassionate Care in Hospital?" So a little bit about me. I'm a general internist at St. Michael's Hospital at the University of Toronto, and I'm also a health services researcher. And my scientific focus is using electronic clinical data to understand and improve hospital care. So I'm the co-lead of something called Gemini. Hilariously and serendipitously, I'm wearing a shirt that says Gemini because we have an office party today. But Gemini is a hospital data sharing network that works with about 30 hospitals across Ontario. And really the major focus of my AMS fellowship was developing and implementing something called ChartWatch, which I'll talk to you a little bit more about when I share my experiences. I've been an assistant prof at U of T since July 1st, 2018. So I was an assistant professor when I applied for this as an early career researcher. I did my fellowship 2020 to 2021. And then just in terms of sort of disclosures as we go through the slides today, I am a part-time employee of Ontario Health. I'm just going to ask everyone if you're not chatting to mute yourselves, and then we can please come off mute if you have comments or anything. I hope it wasn't rude that I muted people, just to make it easier for everyone. Okay, so I am a part-time employee of Ontario Health as a provincial clinical lead for quality improvement, but I don't think I'll be speaking too much about that. And then I co-invented ChartWatch, which was acquired by a startup company called Signal One. And so I do have a conflict there to declare. I actually don't currently have any financial relationship with that company, but nevertheless, I am deeply biased about ChartWatch because I spent a lot of time building it, basically. So what was my proposal for the fellowship? So I proposed, it was ambitious, and I'm not suggesting actually people should necessarily do something like this. The main reason it was super ambitious was because it was building on a lot of work that had already happened. So and I think that's one model of this, is that you can be close to. So my proposal was to implement the ChartWatch early warning system on the general internal medicine unit at St. Michael's Hospital, to evaluate whether it reduced mortality in general internal medicine, and then do a qualitative evaluation about barriers and facilitators to implementation, and how it affects patient-clinician relationships, which really was where the compassion angle tied in. I definitely wouldn't suggest that that's the right approach for many people necessarily, but because I was at the late stage of, we had started our ChartWatch work in 2017, and so I was applying about 2 to 3 years into a project. So that project had been developed and was really ready to be implemented. And so since there was a lot of momentum already and resources and work done to implement it, my fellowship was really focused on the evaluation piece. And so that's why I was able to kind of frame it around a bunch of different things. And I would say, one of the main questions when people are evaluating your application, as with any grant, is kind of like, what's feasible in the 1 year timeline. And so just be clear. And obviously that'll vary depending where you are at your stage in your project. I also chose to opt for a multi-mentor, multi-sort of supervisor model. That's, again, not always the right approach, because I was kind of as an early career researcher really trying to build networks and looking to pick specific expertise from specific people. It worked for me, but I would say different people may choose to just have one primary supervisor, one primary mentor, and that's totally acceptable and fine. It is nice when the mentor and the supervisor have complementary perspectives and skill sets, although again, not 100% necessary, but I think it is generally viewed positively. So my primary supervisor was a professor who was very technically proficient in the machine learning data analytics side of things, and was internal to my organization, happened to be the VP of my organization that was helping lead the implementation of this tool. So was like a very natural primary supervisor. My primary mentor was someone external to my organization, and they're a professor who had a lot of experience related to kind of compassionate, patient-oriented healthcare and health policy. So kind of the nice balance between someone who was very much on the technical side and someone who was more on the compassion, patient-oriented side. And then I had 2 secondary mentors. The secondary mentors were internal folks. One was someone who had a lot of experience, a senior professor with focus on research in homeless populations. And so, really, again, brought that kind of equity and patient-centered compassion lens. And then a different mentor who actually was early career, so closer to kind of like a near peer mentor. And that person had previously done an AMS fellowship or had some relationships with AMS, so they helped me understand kind of how to work with the organization. And then also they were someone who's very involved with public communication of science. And so they helped me with the knowledge translation parts of my project. And that actually really tied in nicely, as you'll see, with some of the work I did. That's really funny that we bought a landline for emergency reasons, and it never rings, and it's just ringing now. But I think lately they've been doing they've been doing a survey in our neighborhood of like what radio shows you listen to, which tells you that I live in like the kinds of demographics of the neighborhood I live in, and the fact that they call landlines. Anyway, so I apologize for the ringing. It should be done too. Okay. The work that I did in the AMS Fellowship. So I kind of did most of what I had proposed. I didn't really anticipate the COVID pandemic, as most people wouldn't have. And so we had to make some tweaks. So our implementation was delayed by about 6 months as we pushed it back to avoid the first wave of the pandemic. We'd actually initially planned to deploy in March of 2020. And so the implementation was a little bit delayed, which meant that our qualitative research and interviews with people afterwards were a little bit delayed. But we were able to do a bunch of different things. This was actually something that because we had extra time, I didn't actually plan to necessarily do, but we decided it was really valuable, was comparing the models, machine learning tools predictions to clinical predictions around to generate trust. then implementing the tool, then doing sort of the analysis. So that was kind of the work that I did. In terms of my experience with the fellowship, um, so I had weekly meetings with my primary supervisor, who is the person within my institution. I had monthly meetings with my primary mentor, who was the external person, and those were very useful. The weekly meetings locally were really essential, just as we were like launching the project and uh, you know kind of very operationally focused. The monthly meetings helped zoom out a little bit and take a bit of the broader view and think about issues. And it was someone external, so they could ask kind of naive questions, which were really nice and give me that external perspective. And just those two structures gave a lot of structure and discipline around this program of work, which was nice. Like there was just like a natural cadence to when I needed to have something to report and to talk about with other people. And then I had sort of ad hoc contacts with my secondary mentors. Through AMS, I was able to participate in a podcast that they hosted to kind of share my work. And then AMS had a partnership with Healthy Debate, which is sort of Canada's leading or one of Canada's leading healthcare communication websites, or sort of health current events and current affairs websites. And so um, uh, they did a couple of articles on my work, part of which was kind of through the theme of compassion and technology, supported by AMS's partnership with Healthy Debate. So that was really nice opportunities for me to both learn about and get experience with science communication and kind of knowledge dissemination in different formats. And then the fellowship hosted a health policy learning session. It was virtual because it was the height of the pandemic, but we had a really productive morning with the folks from McMaster and John Lavis and his group to learn about kind of how to influence health policy with scientific work and walk through a few things. And one of the nicest parts about that session was kind of just like the networking with the other fellows. My experience of the fellowship, I think I'm confident was different than what your experience would be, because we didn't have a lot of in-person events or sort of networking, and I think that's a major focus of the fellowship going forward now. And so, but even just sort of virtually connecting with people and being kind of connected and tied together with a group of people who are all really fantastic, some of whom I'd been aware of or known before, some of whom I didn't know, was definitely one of the best parts of the fellowship. And you can always, even now, I have been fortunate to stay in contact with AMS, and also always can just reach out to anyone who was in my cohort, and even people in years afterwards. So I've had people reach out to me and say, hey, I was an AMS fellow years ago, can we chat about this? Or hey, I'm an AMS fellow now, and I know you were a couple years ago, I wonder if we could chat. And I've had like a handful, I would say, of nice interactions with people that have reached out just purely through this. So the network is, I think, a big strength. So that was kind of my experience. I thought, it was very, very positive, and it's fantastic opportunity. In terms of the application, I think one of the central and really unique aspects of this AMS fellowship is the intersection between technology and compassion, which is kind of neglected, and I think that's why AMS has put a lot of energy in promoting that that nexus. And I think to the extent that your application can be strong, almost equally strong on both fronts, that's the best. Now, when I reflected back on and read back on my application, I have no idea how I received, why or how I was awarded the fellowship. So, take everything I say with a grain of salt, because you can never know in hindsight, why you were successful. I actually don't think my application emphasized the compassion element strongly enough. So I think I probably was awarded it like if I was giving myself the advice, I would have strengthened that part of my application. And specifically, what I think that means is taking time in your application to say how you as an individual conceptualize compassion. Like, how are you thinking about compassion? How are you thinking about technology and the way it can enhance and intersect with compassion? And then how will your project sort of promote compassion specifically? Now, a big part of my project was sort of patient-clinician relationships. And so it touches on compassion, but I don't think I was explicit enough about it. And I would encourage you to be more explicit about it. And if you're looking for any resources, AMS has some amazing resources themselves. So there's the book, and the introductory chapter to the book, I believe, is available for free online. So you can go on their website, and maybe you've already seen it or received it as part of your work thus far in applying. And then also there's this amazing talk by Javid Sukhera, who was a fellow, in 2015. So if you just go to YouTube and search his name and AMS, this talk will come up, and it nicely walks through kind of what compassion means to him, or kind of a more, scientific is the wrong word. That's why I'm struggling to find, like, it's like a rigorous approach to defining compassion through different frameworks. And so that might help as you are preparing your compassion. Obviously, don't skimp on the technological side and the methodological side. So I think my other sort of comments would be, first, having sort of diverse and capable supervision, mentorship, and strong support from your institution are really important. So highlighting that your institution is giving you enough, time or support, and that you'll be, well equipped to be successful, I think, is really strong. And then with respect to your supervision and mentorship, highlighting their specific roles. So it's fine if it's just someone like super accomplished, or not super accomplished. Like, you want someone capable, but you also then want to be very specific about how you're going to be working with them. So are you going to meet them weekly? Are you going to meet them monthly? What are they bringing to your project, and how are you going to interact with them? So I think that helps. And then having very sufficient detail on your method side. There's obviously space limitations, but you need to put enough detail there for the reviewers to both clearly understand your project, but also to feel comfortable that it'll be feasible. And sometimes the methods are not fleshed out as well as they could be or should be in applications. And so make sure you try to really make that clear, especially if it's something highly technical. Just try to make sure that it is understandable to a reader who is, obviously someone that's proficient, but may not be expert in this specific. I think also it's really important for figuring out, how does this fellowship fit with your career and trajectory, and how does it build on your strengths and capabilities and stuff you've already demonstrated, but also will help you take the next step. So it should be clearly tied to kind of your trajectory. And then if it's appropriate, I think it's nice to include patients and families, or, an advisor, someone, that perspective should be brought into your work somehow. And so alluding to that in your project, and potentially budgeting for it, if you need to, some advice on how to kind of do it. CIHR has a bunch of modules, and if you haven't already seen them, probably a lot of you have. But they do have a bunch of modules on kind of best approaches for patient-oriented research. And John is here from OSSU, like the SPORE support units. There's a lot of stuff from CIHR and SPORE on how to engage with patients and their families. So I'd encourage you to think about that and incorporate that into your application if it's appropriate. And it is generally appropriate to budget for compensating patient advisors and things for their time on research projects. Okay, so I think we'll pivot. I'll pause there. The rest of the talk will be just sharing with you some of my work that I did during the application, so you get a feel for like the project itself. But maybe I'll pause. And I know some of the stuff I alluded to, like ChartWatch and the work that I did, probably doesn't make sense until I talk through the whole actual project. But I wanted to pull the stuff about the actual application that's most relevant to you up at the beginning of the presentation. Then we can talk about my work afterwards. So I'll pause here and see if anyone has any questions about the process, the experience of the fellowship, anything like that. Feel free to ask questions about that now, and you can also save them for later. Okay, that sounds pretty good. So you guys know what you're doing. feel pretty comfortable, which is great. Or you have no confidence that I can answer your question. One of the two. So
Oh,
I'll.
Amal, there's a question in the chat.
Oh, thanks. Sorry, it's my.
That's okay.
Let me grab it. Do I have a patient on my mentorship team? Yeah, great question. I did not. We had our hospital's patient family advisory council advise on our project, as I'll share with you. I have seen and I know people have had patients on their mentorship team, and I think that's fantastic where it makes sense to. And I don't know actually if in previous applications, maybe Jocelyn or John could comment whether if the patient was included as a mentor, did people budget to compensate them for their time as mentors or something, or would that be considered appropriate?
Certainly, so there's two ways that mentors are supported. We do have an honorarium, which we pay out to the mentor. It's not a lot of money, but also if it's a patient or a caregiver advisor or mentor, certainly to allocate some reasonable funding for that. And if you have questions, you might check with your organization, and then you can always check in with us around the numbers. I think we have really strengthened that language each year, and we're moving towards required. I'll tell you that. We're not quite there yet, but I think in this day and age, particularly as we think about the patient experience, it really is critical to think about how we partner with patients and caregivers. And there's a lot of people who are very interested in technology and thinking about how this can shift their experience of care. So, and I see John.
Hi, Jocelyn. Thanks. And I would just add that part of the review panel has patient reviewers on it, and of course, that's one of the things that they hone in on is the degree of integration, involvement of patients in your project planning and project execution. I see Genevieve have a hand up, but maybe after she's asked her question and been answered, I would ask Amol if he had any reflection on his the advice he was received from his PFAC, whether it had any implication. Sometimes it does, sometimes it doesn't. Sometimes it's just a nice thing to do. So I'll turn it over to Genevieve.
Hi, Genevieve. Go ahead.
Okay, thanks. Hi, nice to see you too. My question is around, I will be engaging French and English speaking people as part of my application. And I asked the question, I think, to John, but just to make sure, for example, I have a patient partner who is French speaking. So is it okay if I have like a letter of support in French to recognize, the language of the patient partner? Or is it like a disadvantage as part of the application? I mean, regarding that maybe most of people will be English speaking. So just want to make sure I do the right thing to be evaluated in the appropriate way, if I can say it like that.
One of our reviewers is, I don't know if she's from Quebec or not. Right now, she's not from Quebec, but she's fluent in French. So for this competition, it's appropriate. If it happens again in future competitions, then we would probably go to an external reviewer in situations like that.
The other thing you could think about, Genevieve, which is, but you could consider just so like this is pure grant strategy, but you could consider just having a translation, like having the letter of support in French is fantastic. And then if you wanted to translate, obviously you're capable of it, and just translate the letter into English so that your other reviewers could read it. I think that would probably be wise, just in terms of putting your best foot forward. I see another question about letter of supports in the chat from Sarah. I think this is also a letter or a question probably for John and Jocelyn. If we have patient advisors as part of our project, should we ask them for a letter of support, or does it suffice to describe their involvement in it?
It's, as I'm sure you've all read the application requirements over and over again, it's not a requirement to have a letter of support, but I think it's a good thing.
Yeah, perfect. It's also nice. I don't know, like this is, again, I'm editorializing here as someone who sometimes reviews grants and sometimes often submits grants. It's nice on the patient partner side to know a little bit about why they are making the investment of their time in this project. Like, why do they care about it? And that can't really come through in your proposal, but sometimes comes through nicely in a letter and can strengthen your application if it's clear that this person is really engaged and committed to having a relationship with you, because most of that kind of productive interaction comes through a relationship. And John, to answer your question, I think I'll answer your question actually as we go through these slides about how did the patient and family advisors influence the work that we did. There's a couple slides towards the end where it'll give me an occasion to talk about it. So let me talk about the work more broadly, and then I'll make sure to touch on it. Does anyone have any other questions about the application process or anything else like that before I bore you with my own work? Okay, so why don't we move on, but we will...
Sorry.
Oh, no, great.
My name is Marta. I just have a quick question. I was looking for the hand raise reaction, but couldn't find it. I just wanted to quickly ask whether it's okay or appropriate to include like a supplementary section if we wanted to add some like tables or figures to support some of the things we're talking about in the full application section.
So I'm going to suggest that that's not, sorry, supplemental. Is there, so let me think about my answer here. If you're talking about adding additional text, then I would advise against that. One of the things is the reviewers have a lot of applications to go through and they like to have a standard format to look at. And so it's a bit hazardous to add more information. In fact, some applications, it'll be struck out or removed any extra words. If you're adding graphics to your application in order to enhance the written portion, then I think that's appropriate. Has that answered your question?
Yeah, I think so. I mean, this might be a bit unique to my specific application, but for example, if I'm discussing a finding, like a preliminary finding from some data that I have that hasn't yet been published, I was thinking to add like a table showing the actual effect or the statistics to support that, because it's not out there. So kind of just to like show that it kind of exists. And to support that, but if it just adds a burden on the reviewers, then it's not necessary.
If it's a succinct table, then I think that would be appropriate to add, certainly as an image.
Okay, thank you.
Deeply indebted to AMS as well as all of the different collaborators and people I've had a chance to work with. And my email's on the screen if anyone is interested in this area of work or anything else related to kind of hospital medicine and digital care or electronic health records. That's kind of where my research is. And thanks a lot for your time. I really appreciate the opportunity to share this work with you and happy to take any questions.
Thanks so very much, Amol. That's great. And I think there was a comment in the chat about the stories at the end, and I think that does show the real power of the human machine interaction and how we integrate these kinds of technologies into our care processes, whether it be in acute care or other types of care venues. So are there any last minute questions from anyone? All right, I'll let you have the final word, John.
just thank you all. Well, thank you all for presenting, obviously. Thank you all for attending. I will put this up on YouTube, send you all the link to it. But it'll probably take the weekend to get that done. If there are any other questions about the program, feel free to email me. Good luck.
Okay. Thanks very much, everyone.
Thanks, everybody.